Thank you, everyone. It's really a privilege to be here. This has been such an exciting work group, and look forward to reading the conclusions that come out. So we're charged with linking the healthcare system to the broader, well, actually home care to the broader healthcare ecosystem. So I thought what I do, and again, I'm an internist, geriatrician. I take care of nursing home patients. I sort of live this. I see patients every day, and these stories are an everyday occurrence in my professional life. So let me go through a couple of things, if we can get going. So the healthcare ecosystem. This is one man's definition of what the healthcare ecosystem is. And it really starts with, as we heard from Mr. Martinez, and it starts with the patient and the individual and their family, their immediate caregivers, and their priorities. And it's really, that is where we start and grounds everything else. And then what swirls around it are all the other things, everything that Medicare and Medicaid pay for, all of the community-based services, and obviously we need to expand it to health and wellness services as well. And then sort of all their connections. And we've heard what a complex system this is, how complex medical care is, how complex social services and long-term supports are, and how complex home care is. And now we're trying to merge them together to create this new model. So we've got a slow, there we go. So I'm going to go through the following three major chunks. I'm going to give you a summary of what I took out of some of the earlier presentations and how they are important for home care. And then talk a bit more extensively about some of the new tools that are available. Tools that really were not available a year ago. The standards didn't exist, the processes didn't exist. And yet they're critical because they help underpin what I think are the critical processes in managing care and in providing complex care to complex individuals. And that's really care about transitions from one site or team to another, coordinating, so that's sort of site to site, how do we make sure that's safe? Longitudinal coordination of care, how do you make sure that when an individual, such as the ones we've been talking about, go from multiple sites to multiple teams, how do you know the care plan tracks with them? How do you know it evolves as it comes along? How do you know it really gets back to the individual at all points? And then there are other processes like referral management. This is how we touch each other. Healthcare, we're a bunch of silos. We only connect around a patient. We only connect around the exchange of information around a patient. Otherwise, we're pretty happy being our own silos and doing what happens when we get a hold of the patient. But the issue is what happens between the silos. It's the white space. And then finally, just some observations on what these new tools might mean for home health agencies, and really start to stake out a rather different role for home health agencies. And that sort of is the aggregator, guarantor, manager, integrator of all of these services. And I'll give you a few reasons why I think that may be one way to go. So starting off, this is the summary of what I've learned. The future is here. I mean, we've learned that there are scalable models that are really having dramatic results. I mean, this is striking, and they have common themes. They're targeting the 5%, the poly patients, the ones with lots of docs, lots of meds, lots of sites. The high-risk, complex, functionally impaired, behaviorally complex individuals. And then yet, how are we going to integrate around all of those? But we have models that have demonstrated their effectiveness. This is new. I mean, this is great. There's no reason why we can't somehow figure out how to scale these, either scale them down or scale them up. Oops, let's go back one. So the other thing that these are all common is that they've taken the medical model, which we're well familiar with, and they have a well-understood social model. The issue is, how do you integrate the two? What's the overlap? And it really is sort of, we've got to put more medical in the social and more social in the medical. We've seen examples of medical intensity ranging from hospital at home to home visit programs to primary care at home as one end of sort of the medical intensity spectrum, and then all the way to the integration of social support services, the handyman in the home, I mean, that's just a dramatic example of the concept of habilitation, of managing the environment to make it most conducive to successful living on the part of the individual. We also have seen that they've developed really credible metrics on what their costs and their outcomes are. And I think the advice that one of the panelists gave about what the rest of us can do who are not these, highly capitalized groups, we can start by measuring what our outcomes are and having a credible measurement process so that we can go to the people with whom we're going to partner and who are going to pay us and say, here's what we do, here are what our outcomes are, here's what the cost is. And that's sort of the next step. And we really probably all have to do that, or it's going to be very hard to get to the steps after this. But we've demonstrated we have models that improve satisfaction, lower cost, and really improve outcomes. So the other is that the interventions we've seen, they sort of range across the board from really highly complex, medically sophisticated, to, again, the handyman in the home, really low-tech but effective interventions. And I think the message here is you don't have to do the high-tech, complex interventions. You can start with what you can do, and start simple. That's fine. We've seen the impact of these models. So that's what I took out of our sessions from before. Oops, and one more thing. So the other is that we have to have all these parts connect. They've got to be able to communicate. It doesn't do any good for the physician in the office not to know what the home care nurse is doing, vice versa. So communication, linking all this together really becomes a critical function. And again, up until about a year ago, it was really a missing component. So no IT, no coordination. And here's the challenge, is we don't share an IT platform. I mean, we're all the big, meaningful use incented entities are paying millions and millions of dollars for certified EHRs in order to meet meaningful use attestation. We're not going to get big EHRs in home care and in long-term support services. It's just not going to happen. There's not the capital, there's not the demand. It won't be there. We saw the impact of the VA system and what an integrated record has, a national record. And again, it has some holes in it, some potholes in the road, but basically it's a model system. And we've seen how the large systems that use platforms like Siemens and Epic and others can communicate well within their systems, and even those systems up until a very short time ago did not include a line for patient priorities or goals of care. The next versions will address that, I'm sure. But then finally you get down to community-based organizations, home health agencies, SNFs, LTACs, IRFs. They are not going to have this joint platform. So creating a shared platform becomes a real critical need. So how do you go about building this platform? I think it rests on a bunch of things. First of all, it rests on a compelling business case. Why are you going to want to invest in IT if you're not going to get a benefit from it? If your patients aren't going to benefit, it's not going to get you into contracts, it's not going to increase your business, it's not going to improve the quality of your care. You really have to have a reason for doing this. Otherwise, it's like buying the next iPhone. Just go buy it, and, buy the next one. But you really have to have a reason for it. The other pieces are sort of the technology that's come forward in the last year. And there is the potential, and it's growing each day, of a common electronic highway. These are the health information exchanges that are popping up all across the country. They are not everywhere. They're not uniform. A lot of them are not statewide, but in a bunch of states, you can connect from one end of the state to the other using an electronic highway. And I think that's going to be the model that goes forward. And you have to think of these as public utilities. So, rural electrification, it's the same idea. We need health information exchanges going across the country. But once you have this highway, this is how I think of health information exchange. You need a highway, and then you need on and off ramps. How do you get on the highway? How do you get off the highway? You can spend $1 billion on a really complex EHR, which will have the capacity to get you on and off the highway. But we're not going to spend $1 billion, I doubt. The other is, so you need these on and off ramps. How do you get on and off that's not going to cost you an arm and a leg? And then you need trucks. You need vehicles to carry what needs to go on the highway. And these need to be standardized. They have to get under the overpasses. They have to get up the on-ramps and off the on-ramps. So they have specific characteristics, and they need to drive on this highway. And then finally, we need cargo to put in those trucks that is actually of value to the people at the receiving end. And it has to be standardized so you can reuse it and send it to the next person. And everyone has to share that understanding and meaning. So that's what we need for a common IT platform. And again, up to a year ago, many of these pieces were just not available to us. So it is the rate limiting step. And if you think sort of specifically for home health agencies, there are a bunch of use cases that have to do with communicating with all of the other partners that they share, predominantly patient-centered medical homes or primary care practices, as well as the hospitals, the emergency departments, and then also with the long-term support services providers. And then finally, and most importantly, we need different and better ways to communicate with the patient and family, or have them communicate with us, one way or both. And the characteristics are pretty straightforward. It's got to be really inexpensive, it's got to be easy to use, and it's got to be very reliable. And it's got to be, in the phrase of the Office of the National Coordinator, standardized and interoperable. So they have something called the Standards and Interoperability Framework. So they've they've selected the standard. It's called CDA. It stands for Consolidated Data Architecture. That is the standard for information exchange. So I might say, okay, so what is a CDA anyway? This is as technical as this is going to get, okay? I'm an internist. I don't do IT. But I know they send these documents, and they have a special format and a syntax, and they're shared broadly across. And what's really great about this is that you can put as much as you want into one of these documents. You could have 1 billion data sets and fit it into a CDA document. There's no limit on what goes in it. What's limited is the syntax, how it's organized, but you can take different pieces, reuse them, and put them in. And it incorporates all of the old information exchange standards, and particularly the CCD, the Continuity of Care document, which was a meaningful use standard. The CDA is a meaningful use stage 2 standard. So what is a CDA? It's really just a Lego, all right? Again, I told you I'm not a tech guy. This is just Legos. And I think Teresa asked me, so explain CDAs. And I said, it's just like Legos. And the great thing about Legos is that they are standardized, all right? They got the right size, so many prongs, they're this big, but they're also, you can have them in lots of different varieties. So you can put a whole bunch of Legos together, different colors, different sizes, but they all fit, they all go in the same way. And then finally, you can package them in many different ways. So all those little Legos in the bottom corner, they all look vaguely familiar, they're all kind of the same shape, but they've got different colors. They're containing different pieces of Legos. So that's why it's all about Legos. So this is just an example. This is a use case of what's currently available to do right this minute. In fact, it's being done in Worcester, Massachusetts with a Reliant Medical Group, Dr. Larry Garber, I worked with Larry on this stuff. And it starts off with a hospital. Patient enters the emergency room. There is an admission, discharge, transfer, ADT feed that goes out over the health information exchange because they want to make sure that your insurance is intact. It's an automatic feed. They want to get paid. They send it out. Well, what Larry did is he rerouted it to his office. And when it gets to his office, it triggers his EHR to send a visit summary document to the emergency room. Shows up in the emergency room on the bedboard. There's a blinking icon that says, you have outside information. This happens before the patient even gets in the bed. It's once they're assigned a bed. Once you get in the hospital, that visit summary can become the basis of a new document. Gets revised, sent together. It gets sent to the skilled nursing facility, for example, into a software piece that we call C, and it also went out over a larger software piece called LAND. We're from Massachusetts, so LAND and C means a lot to us. And so C is surrogate electronic environment. This is a web-based, all right? All you need is a browser, low-cost software. This is a web-based browser that lets you send and receive consolidated CDA documents from any source to any source. And then what happens is this software alerts the person in the SNF that they have an admission. They do their MDS. The MDS data is harvested by another piece of software developed by one of the Beacon communities called Key High in Pennsylvania. It transfers the CDA document into a CDA document, sends it back into C, which can reconsolidate all this information, and on discharge, send out a new CDA document that's been edited, but many parts reused, and it goes to home health, and it goes to the primary care doctor. You can imagine now drawing all these other connections. You add long-term support services into this mix, then you can see the power of standardized interoperable exchange over a low-cost network. So we learned out of our practice in the Impact Grant that we thought we were going to get thousands of different data sets that each one of these people needed. The SNF needed something different than home health. But it turns out there were 5, and it was what you needed to get back when you ordered a test, what you needed to send when you ordered a test to the hospital, what you needed to get back from the consultant, whether that consultant was the gastroenterologist or the emergency department, what you need to send to the consultant. It's another data set, but these are all nested. And then finally, what you need to send when you have a permanent transfer of care. Any discharge to any site is a permanent transfer. And it turned out that every place that received a patient needed the same information. And these are all nested. So by building the bottom purple square, we actually created all the other data sets. And they're all interoperable and standardized. And what's important for home care is that if you think now, we need the home health plan of care. That's the, also known as the 485. Those data elements in the 485, many of them are already in these transitions of care data sets. Many are not, and they had to be expanded. And the plan of care, a longitudinal plan of care, rests heavily on all of these transition of care data elements, but they too needed additional ones. And the plan of care was based on identifying health concerns, which included medical, surgical, nursing issues, behavioral, mood, cognitive issues, function, and environment, housing, supports, transportation. So any of those could be a health concern, and they are all mapped out in the data sets. And then we also looked at interventions, team members responsible for them, and goals of care with patient priorities. Where this will go next is this bottom red square, anticoagulation, CHF, just examples of condition and medication-based expansions of the data set. You need to know certain things if someone's on anticoagulation, if they've got congestive heart failure. Run through the top 20 diagnoses and you'll have another whole set of data. And then up above, it's really the exchange of care plans. And if you can exchange not so much the plan as you exchange the interoperable critical parts of a plan. Concerns, interventions, goals, and assigned team members. You can exchange that. You can do whatever you want with that information. You can create a care plan. So you don't have to exchange a plan. You just have to exchange all of the components in a standardized way. So these are the parts that you can find in Consolidated CDR, the new one. And it's got bunches of stuff. It goes to 900 pages. So, but finally, we need, how do we build this out? Health information exchanges, and then the acquisition and the use of this really low-cost software. And we need to build out our data sets. So, and there are a bunch of things we can do with the CDAs once we get them. You can do quality reporting, you can do questionnaires and answers for patients, you can convey advanced directives, and I think very importantly, all the referral management issues that it happen, and more. So once you put this in the hands of people who are not linked to Exchange, then you get really the richness of the service mix that's needed to manage these really complex patients. And it will get more and more as technology evolves. So what? Okay. So the so what is that I think without this sort of fundamental shared IT structure, we're going to have a hard time getting the degree of coordination we need, that we've identified that our patients need. And it supports these really high value issues. So for home care. So the question for home care is, now if you plug home care into the midst of this, then the role of of sort of aggregator, integrator, manager, guarantor. There are whole different slice of roles that home care could play, not just a service provider. And this gets home care away from the commodity of selling home care visits. You sell a visit, somebody's going to come around and sell it for less, and that's not a good business to be in. What you want to sell is value. You want to sell, and the value comes with the integration of these services, with making them reliable and consistent and scalable. So the reason that home care can do this is, I think, that really no one does what home care does. It's really unique. It's in the home and brings services to the individual and not the individual to the services. That's the flip of most of healthcare system. And it really has to deal with function. And we all know function is the key to everything here. So no one knows what home care knows, right? And they know that it's the patient and family. It's not just the individual. It's the family and their caretaking constellation around them. And they also know that it's the family that's in charge and the individual that's in charge. And the home care plan is what the patient and family say the plan is. It's not what the home care agency says, or the doc for that matter. And it's what matters most to them. So finally, no one can do what home care can do. And that's provide services on a geographically distributed platform. They're not siloed, they're not based in one particular spot. And they can connect all the pieces. And they can connect, and they can be the bridge between healthcare and social service and support services. And it's a role that there will be a lot of people jockeying for that role. Patient-centered medical homes will want a piece of it. Large managed care agencies will want a piece of it. But home care has, I think, a reason to also stake a claim. So we need to build it out. We need a common connection. We need standards. This system, this IT connection is agnostic. It doesn't care who uses it. It can be the large integrated networks. It can be the mom and pops providing LTSS. But it's going to steadily expand, and it's going to probably serve as the backbone for a new system of integrated services. I think that's it. Appendix is next. And there are some miscellaneous slides in the back.